will talk about today are ways to intervene in educational settings for students with challenging behaviors and autism spectrum disorders. We'll focus later on at the top specifically around emotional regulation. It is an area that causes many challenging behaviors for students that you work with. There's a number of factors that go into modulating moods, regulating behavior. I'll also try to give a description on how to understand when a child is self-injurious, destructive, oppositional. By a little way of background, my background is in child development, education. I was a teacher for a number of years, and then applied behavioral analysis, behavioral psychology. I work in an area called neuropsychiatric disorders, brain behavior relationships, and I work across the lifespan. So working with young kids through adults to seniors, as well as the whole range of cognitive impairments. So students that are severely cognitively impaired, as well as students that have superior brain intelligence. Regardless of the developmental level in cognitive areas, you will be working with students that are explosive, impulsive, difficult to regulate their emotions. So we'll talk about how to understand that. Next slide, please. I'd like to start to talk about past practices and future directions or trends in terms of how we support students in educational settings. One of the first areas that we've moved away from, typically children with autism or neurodevelopmental disorders, are assigned to classrooms, specific programs. What's happening today is that we're understanding more about the child, the family, and then instead of putting children into specific programs, we're wrapping supports around the student. So they've moved from exclusion programs, center programs, to more inclusion programs. In some instances, we have some students that are in educational settings with their typical peers, even though they may have a disability. They're in classrooms with their typical peers. Other things that we do is we have normally developing peers working with students with disabilities. So it's social validation, coaching that moves them from these isolated settings to more expanding and inclusion programs. Suspensions. Kids that are aggressive and disruptive were frequently removed from the school setting. The schools could no longer support them, so they were excluded, they were removed from schools. Today, because of the laws that we have in the United States, the students are required to have a free and appropriate education, including behavioral services in schools. So instead of removing students, there's more support that the schools can access so that the kids can stay in school. Diagnosis. You've heard a number of presentations regarding diagnosis. In the past, diagnosis was inaccurate, and you know that. There was a term that was used, diagnostic overshadowing, this morning. one of the presenters used, and that simply means that if somebody comes into your programs or your clinics and they have a variety of presenting concerns, aggression, self-injury, disruptive behavior, and then someone says, oh, they also have mental retardation, or they also have autism, and everything is formed around that. And it's not the way to think. So we're more accurate in diagnosing. We also know that these co-occurring conditions, so you understand that somebody with autism can have anything anybody else gets, not only medically, but psychiatrically. Those are called co-occurring conditions. And a lot of the children that you work with and that you serve have these co-occurring conditions. Not only medical, but psychiatric as well. And we also know that the more conditions that are assigned, more diagnosis that a person has, it's going to require more resources. So if you have autism spectrum disorder, you have seizure disorder, and you have sleep problems, then you're going to require more services and supports. So the more layers you have, the more supports you have. So what's important in this, in terms of intervening in the classrooms, we have to understand that each of those diagnoses, we have to separate them and say, what does ADHD mean for this particular person? What does autism bring to your classroom? We have to know about these separately. And that we'll talk about a little bit later. That really designs your therapies, your treatment, your educational programs based on those diagnoses. We know if we treat anything, whether you have a medical condition based on symptoms, or psychiatric or genetic, it's based on a cluster of symptoms. And if we understand that, we diagnose that, and then your treatments are tailored to that diagnosis. No different than an educational setting where a child has a specific learning disability. Whether it's math, whether it's reading, whether it's writing, then you're going to assess that, and you're going to design a program that specifically meets that particular etiology. So it is important, you'll see in a little bit, in terms of understanding etiologies. And in a brief way, hopefully I can give you an idea of how to do that. My presentation tomorrow will get more involved and more in-depth of looking at these etiologies. For you behavior analysts, applied behavior analysts, it is critical to do those assessments. So some of the things that we will talk about from the applied behavior analyst side is observing behaviors. When do they occur? Who's around? What's the underlying condition? What's also important, as you hear, is when they don't occur, because that is very important information. Most of us focus on the child has a problem or the person has a problem. Where does it happen? Who's around? Is it the activity? Is it the noise in the room that influences? That's all important information, because those are the things that cause this emotional dysregulation and results in challenging behaviors. What's just as important is when the child or the person isn't having, because that tells us every motivation where that particular behavior is being met. So we have to take a closer look at those time periods where we don't see the behaviors as well. We will talk about that. The biggest changes that have occurred over the years is in actually the behavioral treatments. So shifting from limited knowledge of why somebody would hit themselves or bite themselves or cut themselves in some way, limited knowledge, we have a lot more ways to assess this and a better understanding. It's referred to as functional behavioral analysis or assessment. We'll talk about that in a little bit. So there's been a shift of limited understanding to more understanding of why someone's having challenging behaviors. Behavior modification, everything that we do, and all the research tells us, working with people with autism spectrum disorder, applied behavioral analysis is the most effective intervention. That means a lot of things. That means everything, it's not just one behavioral treatment like low loss or discrete trial, but it's a number of treatments. ABA, or applied behavioral analysis, is the systematic ways that we assess a variety of treatments. It requires a baseline or some initial understanding of what the behaviors are and how much is it different from the person's baseline measurement. So we get an understanding of that, and then we design programs. So whether it's reinforcement, token programs, positive reinforcement, taking things away from students so that they improve their behavior, we have to systematically assess that. And the other very important thing in applied behavioral analysis is the generalization of those interventions. We have to plan for them. So in your classrooms, when you do your assessments, and when you do your therapies or treatments, we have to have an eye on what happens when that student leaves the school or that person leaves your clinic. Can they apply those same skills once they leave? That's the generalization. So as applied behavior analysts, those are the components. Behavior modification, although everything that we do and most successful is under this umbrella of behavior modification related to people with neurodevelopmental disabilities in the United States, there's been this shift to what's called positive behavioral supports. So the main difference is understanding behavior and then teaching an alternative. So the idea of the child is self-injurious, you'll restrain them or do something to teach them don't do that, that really has shifted. And we know that that's not an effective treatment long term. We know that it doesn't generalize. So what we do is we understand behavior, that somebody may throw things to get attention or hurt themselves to get attention. Positive behavioral supports designs programs to teach the student an alternative way to get attention. And we'll talk about this. I have a couple of samples a little bit later on in the presentation. So the mindset has shifted from suppression, reduction, elimination, to increasing alternative behaviors. When we compare using punishments for kids can eliminate a behavior, there are many side effects we know to using punishments, negative side effects. So when we compare reducing by using punishments and reinforcing alternatives, positive reinforcement, those will stay longer because it becomes a part of the person's lifestyle. So it's a change in the way that we approach them. So the interventions today are less restrictive than they were a long time ago. Next slide, please. So things to consider with regard to supporting or working with students with autism spectrum disorders and these challenging behaviors. It does require not only an initial assessment. Where is the baseline? Where is this student? Where is this person? And then we have to look continually over time because things change. Diagnosis change. So we just can't get into the habit of doing one assessment and never revisiting it because we all change. We all learn from our experiences. So we have to make sure that we continue the assessment over time. Variability, the next one, in the child's presentation. We said this is a spectrum disorder. From the early days, and we saw some of the presentations for when the first diagnosis happened, Leo Kanner, autism. Those individuals, if we read the studies, had a lot of severely involved behaviors. They were aggressive, they were disruptive, they were cognitively impaired. And then we take Hans Asperger's, 11 boys who had Asperger's. They were brilliant, they were very bright. So even back in 1943 and 44, there was a spectrum there across, but it wasn't identified. It wasn't called a spectrum. So when we look at each child's presentation, what's important about each child's presentation is that the treatment or the educational plan needs to be individualized. We have moved away from the day and age of protocols. Protocols for treatment. There are protocols for assessments, which is a good thing, standard ways to assess. But in terms of delivering treatments, it's all individualized to that child and that family. So when we talk about, again, differences in behavior modification, positive behavioral supports. In positive behavioral supports, the family is heavily involved in the treatment aspects. The generalizing of those treatments, the family is going to carry on or carry it through at home. So that's what's real important. But we need to know what the variability of that child is. How do they learn? Your educational specialists are probably going to tell you, and this is the way we learn. We learn through seeing things. We learn through tactile, feeling things. We learn through movements. So all of those actually can be applied, as you'll see, in your interventions. When you're working with someone to help a person de-escalate, regulate. We can change the environment. We can prevent it from happening. But it is the critical part is giving that child or that person the tools to withstand the stress or to problem solve or reduce anger and anxiety. So we can use a variety of treatments, and we'll talk about that again in a little bit. Another critical area is understanding maladaptive and challenging behaviors. I hear the word maladaptive, and I understand what it means: aggression, disruption, self-injury. But if you look at the way the kids with an autism spectrum disorder use those behaviors, it's very adaptive to me. Meaning that they gain access to things, they get things taken away from them or removed based on their behavior, so it works for them. Again, it's our understanding. Why would somebody do that? Why would somebody ingest inedibles? Or why would someone bite themselves? There's a reason for that. And we'll talk about how to identify that. The other thing, as you'll see on this slide, the last feature here, is the critical need for partnerships. So, when I say partnerships, not just families, we're working with a population. I refer to them as complex needs. Most of the kids and students that you work with are going to cut across 2 or 3 service systems. So in my areas, you may have somebody that has a medical condition. You may have somebody that has a psychiatric condition. You could have a genetic disorder or problem. So you're working with 3 service systems. And the challenge with that is the fragmentation, the miscommunication of those service systems. Especially in our area, I spend a lot of time connecting with neurology because somebody may have a seizure disorder, and then psychiatrists who will treat the behavioral health conditions. There are some cases where a person may have a bipolar disorder, a mood disorder, and be prescribed a mood stabilizer, which often is an anticonvulsant medication. The person may also be involved with a neurologist who is also writing anticonvulsant medications. So nobody talks to one another. And what happens in some of those cases is the person deteriorates. So it's the fragmentation of those services that somebody has to coordinate. And we do that in our clinic. We have positions called care navigators. You've heard a reference to that, I think, in one of the presentations for the Los Angeles. It's somebody synthesizing all of the data, all of the information to make some sense out of it. So it's that critical need for that partnership. Next one. So as we get into talking a little more about dysregulation, things that may cause difficulty for your students in the classroom, or even difficulty for you to understand, why would a child or a person hurt themselves or hit others, or not respond to your questions or directives. You've heard this, maybe you have heard the term joint attention. By just a simple definition, it has to do with 2 people seeing an object, seeing and sharing an experience, looking at the same thing, could be in different sections or different areas. They will look at the situation or activity, see some enjoyment out of it, and they can look at one another and smile without saying a word. That's joint attention. That's shared experiences. Most children typically develop this, even at earlier ages. Not unusual, 6 to 8 months, 9 months, mother or father carrying a baby, maybe in front, and they're walking and they see an airplane flying over. So the child looks up, mother looks up, they look at one another and smile. They get the message. And oftentimes, children on the autism spectrum do not get that message. They have difficulty in sharing that enjoyment. It's not that people with autism don't experience joy. It's sharing the joy or experiences. This also has to do with perception. So what is very important for classroom teachers that are educating students, making clear that whatever the activity is, whatever the goal is, or the exercise, making sure that it's clear to the student. We can put something on the board, and everybody can look at it on the board, a picture or a photograph, but we will all get different perceptions of what that is. It is very important for us to follow up and make sure if the student is capable, obviously there may be students that are nonverbal, significantly challenged, and severely autistic, unable to do that. But most of the students, we can ask them, what do you understand about this activity? What is it that you're going to do? And for you therapists, if you're doing individual therapy, psychotherapy, for your clients, it is also very important to ask them, what are you getting from this activity? What is it that you're learning from this experience? So when the other areas that I want to mention, that joint attention, you also heard the reference to what's called theory of mind. So as we get to discuss this emotional dysregulation, theory of mind is something that we typically and normally develop. And again, at a basic definition, it is taking the view of another person, putting yourself in that person's position. If somebody is ill, or if somebody is struggling or having difficulty, most of us are able to sympathize. Say, are you okay? Do you need help or support? For people with autism, very difficult. We can teach it, begin to teach it, but not automatically develop. In the United States, in secondary education programs, this is where most of the students with Asperger's are bullied. So we had the referred to as bullying, taking advantage of. And it was related to this theory of mind. Social needs, social interactions, looking at somebody, that reciprocity, back and forth, often is not there. So with theories of mind, the gestures are misinterpreted, misunderstood, and then often leads to these negative interactions. So when I see patients that are young adults, they've had these negative experiences throughout education that lead them to be depressed or anxious. We're still on this other slide here, right?
Oh, that's theory of mind.
Okay. Oh, okay. Thank you. Thank you, theory of mind. So these are things that we have to be aware of. But it is this perspective taking, and often is an issue. A very quick example of how you might want to teach an adolescent to be included in social groups. And we do this in one of our clinics. It is important for adolescents to socialize. And having an autism spectrum disorder, you'll have difficulty just including, getting into a social situation. And I can tell you from experiences, for adolescents that have Asperger's, it's when they get involved and take over the situation, they will tell you everything they know about a specific area, their passion, and it often creates this negative interaction. So we may have a student that will teach, you need to shut up, you need to stop talking. So a student may wear glasses, and we'll teach the social group. When this student is talking too much, just touch the bridge of your nose, because a lot of people that wear glasses will push them back. So it's a social cue, and we teach the student this, stop talking, give someone else a chance. And it's just a simple way to think about that. When we get to this slide here, this one here, just very quickly on this one. So we have, and we talk about regulation, self-regulation. Processing information. There's a lot that goes into processing information. Information comes in. We understand as much as we can. And information is just not verbal. Like in this room, how hot it is, right? That affects our attention. That affects how we take in information. So we have to account for all kinds of information coming in, whether it's visual, auditory, tactile, noise, because it influences. There are things that prevent or block information coming in. Then we have the processing. Once it gets in, how do we understand it? Is it clear? Is it true? There's a number of things that interfere with that. Anxiety, for example. If you have high rates of anxiety, then you're going to miss a lot of information. It's not going to be accurate. You will get bits and pieces of it. And with self-regulation, children with autism actually react on little bits of information. Difficulty with modulating the mood. If something makes them upset, they go from 0 to 100. Just like that. That quick. Unable to problem solve. So that's the processing. And then the output part. So once we get the information, we understand it. The output part, would we block somebody from doing your activities or participating in your sessions? It could be related to the environment. It could be related to the consequence, the experience that somebody has that they fail or they don't want to participate. One other thing very quickly, I'll look at this. Do you have this? So when we look at difficulty with input, we know that students with autism focus on particular aspects of an activity. They don't see the big picture. It's often referred to as seeing the forest through the trees. There's a term that's called central coherent deficits. And so when we're teaching people with autism, we go from specifics to general. Most of us, when we learn something specific, math, calculations in school, we can automatically apply them everywhere we go. For students with autism, we have to prepare them to think they get it one way, but how can we teach them to tell time, not only in the classroom, not only by the dial, but also digital or other means of telling time. So it's taking that small activity and generalizing it. This picture here, this question could be talking about categorizing things that fly, right? So we have machines that fly, we have animals that fly. If you're working with a student, and this is actually a student with Asperger's, who has an interest in dirigibles, right? He says, his answer is, it takes 1,000 cubic feet of helium to lift 60 pounds. So that's what he focuses on. So we have to make sure that if a student learns a particular way, then we have to include that in their educational plan. One other example that I can give, this was an 11th grade senior high school student. that was very brilliant in math calculations. His passion or his area of interest was in America, the Civil War. He knew everything about the Civil War, everything down to uniforms, badges, battles. He was failing miserably in math, but he was brilliant according to psychological evaluation. And the reason why he was failing is that the educational activities didn't work through his passion. So an example that I can give is that the teacher wanted to know about how fast something travels through time, distance. Point A, point B, traveling at 60 miles an hour, how long would it take to get from point A to point B? He could typically solve that very easily in his head. He wouldn't do it. However, if you set it up according to one of the battles in our Civil War, two cannons in different positions, the cannon fires in that distance, he was able to get it. Now, that's not the real world, but in terms of understanding this child is bright, just because he's failing this test doesn't mean he doesn't know it. So you can move from that situation to something else. Can you move on to the next slide, please? So when we talk about these things that interfere with processing, this is, if you see these lines, there are things that prevent or block, and we have to make sure any one of these. So we talk about fatigue and stress. If you were up all night last night and didn't get much sleep, your brain is not efficient. It's not getting a lot of information. So, right now, so it affects it. So we have to understand what might be blocking that. So some of these other areas, as you'll see, sensory. We have anxiety, rituals, but we have to understand that it does interfere. So we can make accommodations so that that information is open, it comes in. Next slide, please. This is an area that begins to talk about this dysregulation. So if we look at processing for your neuropsychologists or whoever does your testing on working memory. So we need our working memory to problem solve, to solve problems. And I guess by definition, that trough, by definition, it means how many bits of information can you hold in your head at one time? If you are in a class or in a situation where there's a lot of information coming at you at one time, you can become saturated, overload. This is pretty consistent with kids with attention deficit as well, that reservoir fills up very quickly, and then it's on overload or overflow. There's nothing more going in. This can happen to us as well. Sometimes it's equated to a computer. So when we talk about the working memory part of this, if you work on a computer and you have 7 windows open on your computer, right? What happens to your computer? Slows down and freezes in a lot of cases. Similar things happen. And this is where the emotional dysregulation comes in. Working memory is also something that helps us multitask in our brain. We typically do this. If you are confronted with a situation that is unpleasant to you, and you're angry, inside, mad, depending on the situation, you're with your boss, you're getting reprimanded. In most cases, even though you're angry, you have the ability to problem solve and say, if I say or do this, I'm going to get fired. Or you can choose other things to do. And I'm explaining this very slowly, because this happens very quickly. It's a response that we have. For people on the autism spectrum, very difficult for them to do that. Once they become overloaded, internal level of arousal, you're going to get the explosion, or you're going to get running away. It's either coming after you or running away. So this is a big area. We have to know how much information can we give this student or this person. What are the modes that we give it? Visual, verbal, tactile, combination. I heard in a presentation this morning about communication. There were some concerns that if somebody is showed in photographs or pictures, in some way that's going to deter that person from talking. That's not the case. The approach should be for all people who have communication deficits. It should be a total, it's called a total communications program. So not only verbal, visual, tactile, all of those things should be put together to help someone communicate. Next slide, please. So when we look at executive functioning concerns, so it's the ability to organize, sequence, abstract information. We have to help the students understand how to do this. Again, this is something that we typically learn to do by our experiences, but for people on the autism spectrum, they have difficulty with organizing and sequencing and abstracting information. I mentioned central coherent deficits. That is a part of this. I'm going to use a term called rule-governed behavior. So for students, think in a structured, ritualistic kind of way that things need to go in order across the day. When it flows that way, everything is fine. But once we get a subtle change in that, the sequence is broken. In school, you may have a substitute teacher, for example. The student responds accurately 100% of the time. Behavior is in great shape. However, if a new person enters the classroom or somebody takes over the teaching, then you're going to have this negative response in some ways. All of this is teachable. All of this is workable. But again, we have to understand with these executive functioning areas that if there's a quick change in somebody's routine, then they become anxious. It's what we teach them to do with that anxiety that makes it successful. And we'll see a few programs in a few minutes here. Can we go to the next slide, please? So what then blocks this output part? So as you see, there's a number of things that we have to take into consideration when we're looking at why won't a student participate in an activity? Are they interested in it? Do they value it? I don't know about you, but I would be less interested in participating in treatment or therapy or education if it's not going to have value to me. Now, for some folks that are significantly challenged cognitively, we have to make those choices for them, obviously. But there are some students that we can actually have them design a lot of their own plans. I work with adults that design their own therapy programs or plans. They're contracts for safety. So adults that have dangerous behavior, I will sit with them and say, tell me what works for you. What is it that can help you when you become upset, that you don't hurt yourself or someone else? And actually write a plan, and then we follow that plan for that person. So it's really finding out what the person values and the expectations as well. Next slide, please. So emotional regulation. So this is where it gets into how do we teach students to regulate emotions? It is really no different than us. You know, if we get upset and angry, we do have that ability to keep that level of arousal, anxious, anxiety, anger. We have the ability to keep it at lower levels. We can call somebody. We can talk to a friend. We can go have a coffee. We can do a number of things that reduces that level. People on the autism spectrum fail to do this. Not that they can't, but they don't have the plan B, if you will. They don't know what they can do instead. That's where our jobs come in. Teaching somebody what to do when they become upset. The primary thing that we need to do initially is help them identify that. Because if you work in this field, you'll see that a lot of times affect, how the person looks, doesn't match what the person's feeling inside. They look okay, but they're having difficulty because something happened early in the morning and they weren't able to resolve that problem. So it'll carry it through all day long. And then there may be a point where it's just overwhelming. And then you see the explosion, and you say, well, that's the problem. Well, not really. If you go back and look at what happened early in the morning, maybe that's the issue. So it's real important for us to help identify to that person when behaviors are escalating. So the challenges with this emotional regulation, it really is the inability of the individual with autism to modulate these internal levels while limiting this overreaction to the environment, stimulation, to teacher directives or demands, or even the social interactions. So when they're upset, negotiating or working with that becomes a problem. So there's a disconnect in the balance. So as we look at this model here, we go back to the other one, please. Thank you. So this is the model we talk about: information coming in, processing information, and then the output part. So we have this input, as we said, the processing, and then the output part. The output is the behaviors that you're working with. When you see a behavior, it's the end result of something. A lot of things may have occurred. What we often do is treat the behavior, once we see it with maybe even a negative consequence, with the idea that that's going to teach that student to be less impulsive. It doesn't work that way. So in order to be successful with a student or a person like this, we have to begin to understand, is there something in this environment that sets the behavior in motion? It sets it going. And then the processing piece. So is it the processing, is it clear? Does the person understand the expectation? And then the emotion, that's the vulnerability. That's where our focus needs to be. Giving that person the tool to decrease internal levels of arousal. As you see, as internal level of arousal increases, you don't have to be on the autism spectrum. It happens to all of us. The more angry and upset you become, you're more likely to say or do something impulsive. And we have all been there. We probably have had situations where we said or have done something that we wish we could take back. That's impulsivity. The difference between us and people on the autism spectrum, their behaviors are more socially unacceptable. The things that they do, but the mechanisms are the same. So what we have to do is modify the environment, make sure that processing is clear, the vulnerability of emotion, and we can do relaxation, we can do removal, and we'll talk about that in a few minutes, so you get an idea of interventions that might be successful. We go to the next slide, please. This is the same model, but we have an interference now. So if you see the interference, and that can be anything. That can be anxiety, that can be, if you have a mental health condition or problem, it could be depression. So if somebody if you have mild depression, just mild depression, your concentration and memory is going to be affected, it's going to be impacted. It's going to take you longer to get information, and you may even be worried about the thing that's making you depressed or the feelings of depression. So we have to make sure that that's reduced in some way because there's some confusion there. And the rest of the model remains the same. It's giving the tools, but making sure that the thoughts and perceptions are clear. Next slide, please. And this is the last one here on this perception part. So now, same model. We have those same behaviors, but what's causing this now is this is our more significantly involved approach. That maybe there's something in the environment that is confusing to them. But for somebody who is unable to communicate, tell you that something is a problem, that again, if you have ever been in a situation where you can't make your point or get your point across, you're going to maybe perseverate, say it more. Same way with our students here. So giving a way to communicate could be visuals, it could be a written message, it could be your augmentative communication devices, your iPads or other things that students can use to help them communicate. Next slide, please. Okay, so when we look at, just quickly, when we look at designing a program, okay, let's keep this up just for a minute. Sorry. So when we look at contributing factors, anytime that we're working with a person, we see those behaviors over in the far right-hand column. We have to, what I call contributing factors. This is what we understand about the person that won't change. Some of you are, by personality or by nature, anxious. You're anxious, right? That's not going to change. You're going to be anxious about something. So as we look at these contributing factors, if someone has processing deficits, if somebody is ritualistic, those aren't going to change at all. So we have to think about making accommodations for that. So if we see We see the contributing factors. We can predict, in some cases, what's going to cause that behavior. So it's our job to work with that person to reduce those interfering kinds of behavior, interfering processing deficits, like giving someone a way to process better, making information a little bit smaller. Next slide, please. This is functional behavioral assessments. I'm not going to spend a whole lot of time on the interest of time here because we have other people that need to present. It is required. You should be, anytime you see a challenging behavior, this is a process. And it requires us to understand etiologies for behavior. In my workshop tomorrow, we'll talk a lot more about this, the components of it, and how it's used. It is a process. It requires information from a variety of sources to understand the person and the behavior. If we understand at a basic behavioral level that all behavior, regardless of what anybody does, serves a purpose for us, that's a basic. Same way with the students. No one does anything for the heck of it. There are reasons for all our behavior. The challenge for us, especially with these complex needs individuals, is to figure that out. Functional behavioral assessments can give us the observable. The child or the person is doing this behavior to get attention, or they're doing it to escape their activities. And that's basically what this says. It's the interaction between the person and their environment. So the observable ones.
The reasons of behaviors were confused.
No, you're okay there. You're okay.
That's the reasons.
Okay. I don't know how we got disconnected on slides here, but so the point of this is observable. Things that we observe are good information. I'll be talking about behaviors that are beyond the observable. The ones that you will sit and say, why did the child do that? Nothing was going on. They were absolutely happy, but all of a sudden it changed. So there are ways that you can assess that as well. Okay. This is just a very quick form. Is this tomorrow's presentation? No? Okay. So this form here, this form here is a way that we can assess behaviors. So from the behavior analytics side, ABC, antecedent, behavior, consequence. Those are important bits of information. So those three areas. What sets the behavior in motion? What causes it? What do you do for it? Because if we understand behavior, something happens, you do something or not respond, and then something happens to the behavior. You can be very good at identifying the behavior, but your intervention can actually maintain it. What you are doing sometimes makes the problem worse. So when you get this information, all of it, time, date, activity, those are things that are critical in terms of finding out etiologies. Okay. Next slide, please.
Strategies and possible.
Okay. Classroom. These are some of the interventions in the classroom. So very quickly I'll show you a few that may be successful. This is on regulation, right? Teaching self-regulation. And then, so I apologize for people coming up after me here. Just very quickly, thinking about the things that cause this emotional dysregulation, teaching general strategies to help students calm, taking a break, very simple to do. You have to teach the students to take a break. You have to help that student identify, because they will not be able to tell you, I'm upset, I'm angry. What they will do is behave. They will have disruption or aggression. So we have to recognize that. When does it become challenging? And then, when can we intervene and teach that student? So one of the things we can do, as you'll see in a minute, is a break card. Other rewards, incentives, behavior reinforcement. We know that positive reinforcement, praise, attention is very effective for teaching these skills. Here's the next slide, please. You can simply make cards that say break on it. And we teach the student to put that on their desk when they're escalating. When they put it on the desk, we can, and it's before you get behavior problems. What you don't want to do is the behavior escalates. You have an activity in front of a student, they become upset, they're disruptive, and if you remove that task, what does that teach that student to do? And if I want that to go away, I can just be disruptive. So our job is to intervene on the front side before it happens, and we can teach the student that. Next slide, please. So here's this is a student here, 7-year-old student that is disruptive. He screams, yells, falls to the floor. He has these escalating behaviors. The functions of these behaviors, difficulty communicating. Couldn't tell us when he was frustrated. So what I did on the interview, his passion was volcanoes. So he had everything about volcanoes. Everything. That was his passion. Not functional, but would know everything about it. So what I did was took that non-functional skill and made it functional. So I asked him, when you're calm, what's the volcano look like? So he shows a dormant volcano. And I said, when you get angry and mad, what's it like? And he drew this. So we taught him to use this. So his affect didn't match the inside. So periodically the teacher would ask him, how do you feel? And he would point to either a volcano, this is before the disruption, or the calm. So we had an idea how, before he would escalate. Next slide, please. And I only have a few more here. Very quickly, this is an easy thing for classroom teachers to do. So it's basically catching students being good, if you will. In the classroom, students that don't raise their hand, students that don't stay in their seats, students that run out of the room. This card we place on the desks. And what the teacher does, as he or she is teaching, if the student is in their seat or they raise their hand, they walk by and either put a star or a check mark on it. So it's you reinforcing the alternatives. So this is the alternative to your problem behavior. Very simple to do as you're teaching. You can walk around, takes a couple of seconds, and once the card is filled, that person exchanges it for an activity of their choice. Positive reinforcement. Next slide, please. Self-assessment, self-monitoring. We will go to, so this is a self-assessment program. Again, we want students to be able to self-assess. We look at this left-hand column. we see those are the alternatives to your disruptive behaviors. That's where our focus is. So this is teacher directed. So students, ones that are able to respond to this program and to identify they're in their seat, they're keeping their hands to themselves. Periodically, someone goes to that student, 9 o'clock, 9:30, and asks, are you keeping your hands to yourself? This isn't a reinforcement program. This is just to help the student identify self-assessment. We, in many cases, require students to self-monitor, meaning be responsible for their own behavior. But in most cases, they don't understand if they are accurate or not. So our first job is to teach them. This is how it's done. You ask them in an over period of time, once they have self-assessment, meaning you go to them and ask them, did you keep your hands to yourself? Did you do all of your work? Did you respect the property of others? And if it's accurate, yes, then this student, you can just go to them periodically, maybe in the morning, in the afternoon, so that they break the whole day to short segments. A lot of programs, you're working with students, will wait to the end of the day and then ask, how did you do today? And it's too long, so you shorten it up. Next one, please. This one here is a musical interludes, another classroom. So what I did with this one here, teachers at different time periods. If you see those 30 seconds, 2 minutes, 5 minutes. So what I did was had an audio tape in the classroom. Students are working. We taught teachers to be alerted, and at different time periods, soft music would play. So in that cued the teacher to assess, to go around the classroom and assess. So if students were in their seat, they got a check mark. If students were out of their seat, not attending, they were bypassed. They didn't get it. So the idea is that when all the check marks, the boxes are filled, again, exchange for a reward of their choice. Students very quickly learned when that music came on, if they weren't working during their seat, they didn't get a check mark. So you focused, and the students had difficulty picking up time periods where the music would occur. So we really over time here. So as we think about these programs here, this is another classroom intervention that is easy enough to do with a classroom of 15, 20, 25 students. If the teacher is alerted, I don't know clearly on how your classrooms are structured with numbers of students and support staff. I'm assuming that you have not only the teacher, but you have other people in classrooms with the teacher? No, just the teacher. You can do this with just the teacher, but you get the idea of this. So when the card is filled, exchange, reinforcement. Behavioral, positive reinforcement, ABA, interventions and treatments. Next slide. Can you go to the one that, okay, this is, right, okay. So this is a little fellow here, AJ, this is Robert here, and if you can think about his problem behaviors, disruption in the classroom, so again, out of seat, he was aggressive towards other students, would hit, kick. He also had temper tantrums. I want to mention something about temper tantrums. Temper tantrums are different than meltdowns. When we talk about people with autism, do you hear the term meltdowns? Have you heard that term before? The differences between them. Meltdowns are this catastrophic, overreaction to either the environment or the situation. So it can occur at any time. There's difficulty understanding etiology, but it really is this overwhelming feeling of stress and anger, and then you get this explosion. Temper tantrums, however, are more related to attention, escape, somebody taking something away from the student or the person not getting what they want, and then they have this reaction. So there is a clear difference, and the reason I make that clear, your interventions or treatments are going to be different because they're different etiologies. So when we look at the first one, the explosion, the over amount or overreaction, that's emotional. They're both emotional, but ones that we can give the tools to that student to relax or calm. The situation where we have temper tantrums, then we have to work with that student and prevent them, but also give a way to get attention or escape instead of hitting other students or destroying property. So Robert, what we did with Robert here, temper tantrums and destroying property, you see these are functions of behavior. So we wanted to find out what the etiology, and Robert had these behaviors to get attention, to get escape. He didn't want to do an activity. He didn't like what the teacher gave him. He would just be disruptive to get that away from him, and it worked for him. The other thing that we, in terms of our behavioral intervention, and you'll see this is called non-exclusionary timeout program. So what we did was we asked Robert, what do you like to do? Things that you like to do, because we wanted to use that as a reward, incentive, reinforcement. So Robert liked watching videos. He liked doing artwork. He also really liked helping the teacher. And obviously, you can't have a student being a teacher's helper who's disruptive and aggressive. So we took that as an incentive for him. So this is called non-exclusionary timeout. If we understand timeout from positive reinforcement, which probably a lot of you may use, that if a student or person is disruptive, they're removed from that situation that's reinforcing to an area that is void of reinforcement. So, timeout chair, another room, you're removing that, and it's contingent on that disruptive behavior, aggression. And that's punishment. It's a reduction program and very effective, and it's in the literature as a way to reduce these disruptive behavior. This program is what's called non-exclusionary. So you can actually time a student out at their desk, at their seat, without removing them. And this is how we did it. You see this star, right? So Robert wanted to be identified as a helper. So we would give him a badge. So this badge was the helper's badge. So anytime that was on, that meant Robert's doing okay. He's not having difficulty. He's identified. He gets attention for the helper, right? So if Robert has a problem, so what this would be on his desk. So, I'm sorry, the next slide. So, and again, these are incompatible with our identified problems. So our job was to teach Robert other things to do. So as long as Robert had the badge on, he could get check marks. And if you see, these areas are all alternatives to the problem. If Robert was disruptive, badge comes off. Robert's still in his seat, but he doesn't have the opportunity to earn checks or check marks. And it didn't take long for Robert to learn that. The incentive for him was watching videos, so as long as his boxes were all filled, he gave it to the teacher, he could watch a preferred video for a short time period of his choice. So you can time somebody out without taking them and removing them to another area. Next slide, please. This is another way that a teacher can deliver a consequence for a behavior. This is a similar kind of a program. It depends on the child, it depends on your classroom. The stop sign means that as long, and this could be for the whole classroom as well. So if you have a classroom that is disruptive, that stop sign can be posted anywhere in the room. As long as that's posted, nobody gets rewarded. So it's kind of a group contingency. Somebody is doing something that's unacceptable. The students, I have to know that. You have to explain it before you use the program. So for a whole group, if somebody were disruptive in this group, the stop sign may go up, and then you don't get your dinner tonight. So it's another way to use an intervention to stop somebody from having difficulty. Next slide, please. This one here for in small groups. So you see green light, red light, right? So if you're doing a morning activity and you have a circle of students, if again you see that a student is disruptive, you can simply, again, it's an agreement, and a student has to understand when you see the red sign, that means that you have to stop and think about what you're doing. So it can be individualized to one student in a whole group, like this audience here. If I talked to somebody prior to coming in here, and I said to you, you see this sign here, if you're disruptive, I'm going to turn it like this, and that means that you need to change what you're doing. And no one else has to respond to it. So it's a matter of getting a person to understand that. We've also used things on the teacher's desk. We've done things like in some classrooms, teachers may have photographs on their desk. So in seat work, everybody's working quietly. So the student, again, is aware of if that picture is down, that means that they have to correct their behavior. I mean, it's something that they're aware of, they're constantly checking. So if the photograph is up, I must be doing okay. If it comes down, then I need to check myself. And you can do it, again, for individual students as well as the whole group. Okay, next slide, please. And this is self-assessment, self-monitoring. High function, okay. So these are higher functioning students. So we're looking at students that are more involved, that need visuals. So for high functioning students, this is what we use in terms of teaching self-assessment, self-monitoring. As I said before, you can't expect, none of us can self-monitor unless we're able to self-assess. Unless we're able to say, I'm meeting expectations, I completed my work, I did my job. If we don't have that, then we're unable to self-monitor. It also comes with self-discipline. So if we identify what are expectations, what is it that I need to do? How do I know that this job is good or this work is good? I can assess that. again, for many of us, if you were in education in universities, how many of us wait to the last minute to turn in a project or a thesis? And we know that if we wait to the last minute, that work really isn't the best. We know that. So that's part of self-assessment. So when you're working with students, we have to teach that initially. They just don't automatically have it. And sometimes it requires discussion. It requires, in some cases, modeling or demonstration. This is what I mean when we say working quietly, or this is what I mean by your activities are completed. This is how it's done. So it may require you to sit down and explain that, demonstrate, and say, here's what it looks like. Because then you have a model. And the student can actually look at that model and say, yes, I've done that. So once self-assessment is completed, you don't have to do it anymore. It's just that beginning part. And that's why we solve for more involved kids, going to them every half hour, every hour, and asking them, how do you think you're doing? And then you provide that feedback. For high-functioning students, this is really what we want them to be able to do. So we look at these positive interactions with others. We look at, can you remove yourself when you're upset and angry? So how this would work is if the student is upset, angry, they actually remove themselves to an area to calm down. Later on in the day, your job or our job is to go up to that student and say, how do you think you did? And that student should be able to tell you, I was upset. I removed myself, and we didn't have a problem. So that is that feedback that you will provide for that student because they need that feedback. Next one, please. This is a simple problem solving way to look at how do you teach problem solving. So if we look at what the problem is, what did the student do? These are negative behaviors. Those are the behaviors that the student engaged in or the person engaged in. And I work with this form for adults as well. So once we identify, describe, operationalize the challenging behaviors or the negative behaviors, then we say, what's the alternative to that? So if it's destruction, if it's aggression, if it's yelling, screaming, then we're going to identify that alternative. And that's what we're going to teach. So it takes a situation that the person became disruptive, and it breaks it down into smaller sequences, and then teaching the alternatives to that. If you ask someone on the autism spectrum, after an incident, they have exploded and destroyed or not responded to you, you ask them, tell me what happened, they're going to have difficulty with sequencing the events. They can tell you what they did, but they can't tell you what caused it, what made you more upset and angry, what were the sequences. So in our cases, that's our teaching moments. So if we can identify problem happens, escalation, fuse, whatever the person does to explosion, then our teaching moments are in that fuse or escalation. So at lower level, if a person is angry and upset, they may perseverate, say things over and over again. They haven't escalated to a point where they've exploded, if that's the first sign. Or there could be an affective change. Once we see that, then interventions need to occur. When we do interventions, the way we should think about it, the first thing is prevention. So if you're real good at identifying the cause, of behavior, we may be able to prevent it by adapting environment, delivering information in a less complicated way, delivered by a person who has good interactions. Prevention is great. However, that's only a small part of what needs to occur. Remember the vulnerability of that student. Our job is to teach them what they can do when they get upset, when they're escalating, when they're mad, when they're angry. That's our job. So if we work on both sides of that, prevention is very helpful, but it doesn't solve the total problem. Giving the skills to that person is the next thing. But this is a form that's used, and then we can ask, did it work for you? So any incident or situations you have for high-functioning individuals, then you're going to break that down into a smaller sequence. Next slide, please. And this one is...
Problemy behavioral groups.
I'm sorry?
Problemy behavioral groups.
Oh, goals. Okay, so very quickly on goals. The only thing I want to tell you about goals, and it is important when we design goals for students. We have to make sure that it's based on some kind of beginning information, baseline assessment, academic, educational assessment, psychological or neuropsychological evaluations. And that understanding of the baseline of the person, how they take in information, how they learn is critical on the front side. Then we design or develop a goal. When we're talking about whether it's academic or behavioral, the first thing that we do is prioritize. So when we think about goals, we have to prioritize what is important. Whether, again, behavioral, we think about behavior. That's easy, at least for me, to prioritize. If you have behaviors that are life-threatening, dangerous, people are going to get hurt, that takes priority. If you have interfering behaviors, so priority are very severe behaviors, and secondary to that, you may have behaviors that are annoying. When I say annoying, somebody may be talking a lot, over and over and over again, or they may be oppositional, not listening to you. Those are secondary to your aggression and disruption. They all need treatment, but it's again prioritizing what is the most primary important thing. And then when we develop goals, educational goals, right? The student is going to perform at some level. It has to be clearly operationalized, whether you're working on a math activity, an art activity, a movement activity. There are a specific goal that you want that student to achieve. And that has to be defined of what that is. What is the student going to do? Under what conditions are they doing it? Are they pointing? Are they talking? Are they writing? And then how am I going to measure that? To make sure that they've achieved the goals. Those are three critical and primary things that need to be established in a goal. You will have a long-term goal. You may have a goal for the year when the student comes into your program. You're going to take that year-long goal and break it down into a smaller component. That's what you're going to measure and track and monitor. This is the goal part?
This is long-term.
Yeah, sure. Okay. Long-term, short-term. So we have this long-term goal of what we want the student to achieve. And then, again, it can be in any area, social, academic area, behavioral area, And then we're going to, again, define what that means. But I can't say enough about monitoring and tracking the goal. And it can be as simple as Adam identifies his mother in a family photograph when presented 10 out of 10 times for 2 weeks. That's a goal. So I know clearly when I present a photograph to the student and I say, where point to your mother, it's going to point to the mother 10 out of 10 times. And it's just a simplified way of kind of describing what we're talking about. But in terms of setting goals, higher functioning individuals, obviously the goals are much larger. You don't have to get to those specifics. And in most cases, you can actually have the student monitor and track their own data. High functioning students. More severely involved students, even getting eye contact can be a measurable goal, which some students with autism is huge. So in that particular case, you would be sitting across from a student, and maybe you do 10 trials. You sit in front of the student, say, Adam, look at me. You wait for the response. Adam gives you eye contact. Good job. Way to go. You can use verbal reinforcement, tactile. So maybe a student likes something cool. So the person looks at you and you can give them something cool to the touch. So sensory areas, sensory reinforcement in those particular cases can be very effective intervention. So the whole point of this goal is identifying it, establishing it, and monitoring and tracking it. Next one, please. So why don't programs work? Why aren't they effective? How many times have we used behavioral programs and then you'll see that if the student responds very quickly, we say, oh, we have it. This is working. And then what happens after a period of time? The behaviors decrease. The person doesn't respond. So when we talk about programs that are ineffective, it has to start primarily with the incentive, the reward. So if you are setting up behavioral intervention programs that have a reward system, reinforcement, stars, stickers, verbal praise, and you see that that student responds, improvement in goals, behaviors decrease, and then all of a sudden you see the behaviors decreasing, or that the student is not performing like they did initially. The very first thing that you're going to look at is your incentive. What is it that you are using as a reward? No different than us. If you set up a reward system, continue with it without changing, we satiate. It gets stale. So you'll see a decrease in the performance of that student. However, if you have a great assessment, you're using reinforcements, and you know that reinforcement or that incentive is really what that student wants, and you are still not having success where you see a decrease, then somebody changed the rules of the game. Somebody made a quick change in the steps of the plan or program. And that's related to what's called treatment fidelity. So any program that you're using, any behavioral program, somebody has to make sure that the program is implemented consistently. So somebody's job, if the plan is written, implemented in your classroom or in your clinic or hospital, that somebody has to go and make sure that it's being implemented according to how it is structured. Oftentimes we see that subtle changes in the program, student improves, and someone says, oh, we no longer need to do this, that creates a big problem. So those are some of the things that you have to be aware of with regard to inconsistency in the program. So we'll talk about this in my session tomorrow, more specifically about the plans and program. Okay, so this is kind of a summary of things, and then we'll take some questions. So as you see, this presentation really is looking at kind of the emotional dysregulation, some of the things to be aware of, just in general, the presentation of that child, the etiology or understanding of what's interfering with that child performing, learning in school, what's the understanding of the reason for behavior, the functional behavioral assessment, again, which is very critical, and we have to make sure that we get an idea, because if we don't do that, if we don't have an understanding of the etiology, then we're going to make things worse. Actually, we're going to create bigger problems. And it's no different than us going for a medical diagnosis. If you're diagnosed with flu symptoms and you're treated for a heart condition, that's going to be a problem. But you have to know what you're looking at. The same way with regard to understanding behavior, and then the behavior interferes with the student's ability to learn. So if we're looking at prioritizing what we need to focus in on, if a student is constantly disruptive, aggressive, and causes difficulty for your classroom, you have to address that before you get to the academics. It's not that you forget about the academics, or academics are less important. You really have to get established and maintain control over some of the behavior so that the student is able to learn, to look at you, and to respond. These other areas in terms of providing care, it's a complex need, so you need to access information from all the partners. We talk about parents all the time because they know their kids, they know what works. So we rely on a lot of information from parents on best ways to approach. What do you do when you're in the community and your son or daughter has a meltdown? Tell us what you do, how do you handle that? Because we may be able to incorporate some of that in the classroom. Families are included in the development of the plan. Again, that's the difference between the behavior modification programs, management, to now positive behavioral supports. And I want to make a distinction. They are one and the same in majority of the areas. It's based on learning theory, right? Reinforcement, learning from your experiences. The differences between behavioral management is we're managing the behavior, we're controlling it, less interested in etiology, but we need to take control. That really has shifted over to the parents involved. And for adults, as I mentioned before, in my treatment plans, I have the adults create their own plan, so they're invested in the plan. And then the difference is generalization of those interventions or programs. Securing expertise. We hear that all these co-occurring conditions, and we'll talk about that tomorrow as well. We heard mental health conditions. I'm hearing that a lot of students have some trauma issues, right? Post-traumatic stress disorder. Those play a role in terms of behavior, obviously. And what is it that we need to know about that? Because if that's the case, if we can understand what the traumatic event may have been, physical or sexual or any other negative experience, then we have to be aware of that, because whatever we're doing in the classrooms or in our clinics, our intervention shouldn't recreate that trauma in any way. We'll have to figure out something else to do. Again, talk about a little bit more about that tomorrow. And then the expertise, as I said, getting people to give information, and then that applied behavior analytic approach, that systematic approach. So with that, we're going to take some questions, or is that what we want to do?
Итак, значит, есть возможность задать пару вопросов, у нас осталось всего 5 минут, после чего мы идем 15 минут отдыхать. Я вижу ваш зрительный сигнал, что вы уже готовы умереть. Я надеюсь, ни с кем не случится истерика. Да, пожалуйста. Сколько человек в классе? Неужели 25? Может быть, это перевод не такой? Сколько человек в классе?
You can have, depending on the inclusion programs, yes, there can be 25 students. There may be 4 or 5 students with autism in the class. So these would be normal peers in a high school classroom. And you may, so teacher, classroom assistant. So we have autistic support classrooms, 8 students, 1 teacher, 2 classroom assistants, 3 staff for 8 students, severely involved students. So that's called, in the United States, in our state, we have what's called autistic support classroom. That classroom is specific to students with autism. But the inclusion classrooms, high functioning, there may be a classroom with 25 or 28 students, there may be 2 or 3 students in that classroom.
Коллеги, последний вопрос. Часть вопросов зададим Джону завтра. Просто морально я не могу вас дольше держать, потому что тут упадет образ. Один вопрос и кофе.
Я могу сказать...
Нет, переводчик.
Добрый день. Слышно? Добрый день, Джон. В самом начале вы сказали, что опыт показал, что в течение, допустим, ранее, на 20 лет назад, если смотреть, то были неточности или неправильные методы лечения. И сейчас это видно. Насколько вероятно, что сейчас есть подобное? То, что сейчас, возможно, есть неправильные методы работы с людьми, которые не принесут в итоге результата.
So, restraints. Physically molding students for the purposes of behavior elimination. In the United States, every national group, 20, 25 years ago, restraints were seen as therapeutic, effective for people with not only autism, but neurodevelopmental disabilities. An effective way to reduce aggression and self-injury. Today, every national group will say there is no therapeutic value to a person being restrained. We talk about holding therapy. We hear that a lot, right? When somebody is in restraint, there's no opportunities to learn a thing. And that intervention actually causes more difficulty and challenges. I get involved in court cases, legal cases, in schools that students have broken arms, injured, or in physical restraints. This is in the United States. So, and the idea is that, well, we're holding that student so that they don't hurt themselves. We can be just as effective because we've learned so much over the years that we don't have to use restraints as a behavioral technique. But restraints, if they are used, they're only used in safety situations, period. So if a student is hurting themselves or hurting others, you may have to hold them to get through that crisis situation. It is not as a behavioral treatment. ABA, applied behavior and analytic approaches, are the primary successful interventions. And there's a lot of them. Insurance companies in the United States approve applied behavior analytic techniques. So 25, 30 years ago, visual screening, physical management, interventions that were painful or caused some uncomfort to the person, those are no longer used at all.